the idea was to increase the collaboration and get the most value out of medication reviews was to be centrally located in a medical centre. So I had that idea before going in and thinking maybe this is also a good research project. I had started my PhD and was looking for medical centres, and I came across an article written by a GP from Brisbane, and I took by chance that his email on the paper was still active, and so I sent him an email with what we were planning to do as the research project and the concept. And shortly afterwards he emailed us back saying he was very interested, he had thought of similar type ideas, would be happy to meet, and then a week later I started working here. So it was, you know, even though we had the ideas and other people probably had similar ideas in the past, it was sort of the right place, right time. You know, the medication review funding was there for it to happen, so it was financially viable, and so that's really how it came about. You know, it has to be financially viable for it to go, otherwise it won't. And so why ours worked was the medication review funding had come along, and we were able to adapt that to our current situation. So we still had to go through the current community pharmacy, but we were able to have agreements with the local ones which captured most of the patient population, whereas no one had done that before. And now with the business rules changing to direct referral to a pharmacist to do medication review, the business model can extend even further. So the way that GP would usually operate, for say if they're referring a person to a specialist, it would be via direct referral. The GP would directly say, I want you to see Dr. So-and-so for a review of your cardiovascular disease. But the same thing wasn't happening with medication review, and that means the utilisation of that service wasn't being used because they weren't used to doing it that way. And because there was a middleman, so to speak, the pharmacy was the one getting the referral and then having to find someone to do it, the time in which it took to do the whole process was quite long. And by having, you know, the direct referral process, that has sped up substantially. And because it's a direct referral, the GP and pharmacists have then developed a relationship over time, and recommendations and things like that are trusted, and there's a greater uptake of those recommendations because of that. So it really was that change in business rules which has allowed, I think, this model to grow from what it started off as. Once we started publishing, we did have both pharmacists and GPs contact us on, you know, how they may set that up, and so I've helped a number of pharmacists and GPs set up a similar process, and presenting our results at conferences, national conferences, and internationally. People get to hear the work and then therefore go then and try and apply it in their own setting. So I've got hundreds of emails of people wanting or asking advice on how they will go about doing that, and and I'm happy to help. Because I think it's for the greater good. But yes, it has led to an expansion of other people now doing it, and we've had conversations with departments of health and ageing who are also considering this as a potential option, and so there may be additional funding, maybe, hopefully, in the future by having a pharmacist here in the medical centre. Because there's a wide range of roles which a pharmacist may conduct beyond medication reviews within the medical centre, which are obviously not funded, which would add value in terms of improving the quality use of medicines and those sorts of things. And so, it's very humbling to think that the work that we've started has had this flow-on effect, and we certainly had government interested as well. So it's very pleasing.
Anybody out there?